Moving on to our next keynote address by a distinguished speaker, Dr. Sheila Balakrishnan, an eminent obstetrician and gynecologist from SP Wellford Fertility Center, Trivandrum. She'll be speaking on a highly relevant topic, ensuring safety and good practice in ART, clinical and lab strategies. Let us warmly welcome Dr. Sheila ma'am to share her insights with us. Over to you, doctor.
Right. At the outset, let me thank Dr. Krishnan and the entire Advances team for having given me this opportunity. I've been associated with Advances as faculty ever since its inception, and I can't believe the 25 years is over. So thank you once again. And my talk is on safety and good practice. Actually, I'm concentrating on safety, safe practice in the IVF lab. But as you all know, safe practice and good safe practices and good practice all go hand in hand, and so I will be skimming through good practice, not going into too much detail. Right. So 1978 to 2025, 46 years of ART. We have made huge progress in reproductive medicine, biology and technology. Our tools have become more complex, and along with that, complex tools bring newer problems. And we're all familiar with Murphy's Law. If anything can go wrong, it will, and that too in IVF. So what is the most important issue in every clinic? Most of us are, for most success rates is definitely the answer, but patient safety is also equally or even more important. So all our lessons, risk and safety management, it started all with lessons from the aviation industry. They were the first to incorporate a culture of safety. So safety above all is the motto in aviation. And I think that is very important in medicine also. But remember, in aviation, safety is invariable and adverse effects are rare, but the same cannot be said in medicine. So infertility and ART is an area where risk and safety management can play an important role because of the existing rules and regulations everywhere in the country, and we have also followed, and the QA/QC/QA procedures. So, and remember, safety is everybody's responsibility, not just the clinicians or the embryologist. All safety protocols should be dynamic and are to be constantly reviewed and updated based on new knowledge and mistakes. However good the protocol, unexpected and unintended circumstances can occur that require deviations from the protocol. That is very important. So mindfulness and situational awareness are mandatory to adjust to unexpected events. The main principles, as in anywhere else in RSM, say what you do. Protocols and SOPs describing all the ART processes in the clinic and in the lab. Have checklists and encourage your staff to use and complete the checklist. Pre-procedural briefings, very important, and teamwork. Ensure all your consents are taken and signed. Witness as well, the patient, the couple, the doctor, and the witness. Identification and witnessing at each stage. Now, when problems occur or litigation occurs, etc., there are two main questions. The first is, as in any surgical procedure, was ART indicated? So that is something that we all need to think about. And was there adherence to the provisions of the ART and Surrogacy Acts, especially in the case of third-party ART. Now, just a few words about the clinical problem. These are just all real-life scenario which we saw when we were working in SAT. They were all referred from us. A patient with Turner XO underwent ovum donation. It was a triplet pregnancy, reduced to a twin pregnancy. She was admitted at 24 weeks with excruciating chest pain and could not be revived. Classic case of aortic dissection, which could very well have been prevented, because we all know that Turner is a relative contraindication to pregnancy. And when I say relative, it is relative because all patients with Turner have to be screened for not only the aorta thickness, the intimal thickness, and all that. And again, and very, very important, I think single embryo transfer has to be done in a Turner syndrome if you are doing it. There is absolutely no place for multiple pregnancy. It should not become a multiple pregnancy. Another scenario, a woman underwent IVF, frozen ET, conceived with a HRT cycle. At 12 weeks, she developed acute breathlessness and cyanosis, detected to have a massive saddle embolism of both the pulmonary arteries, and underwent emergency thrombectomy. Fortunately, she survived. On taking a detailed history, it was found that she had she was found to be ANA positive because of joint pains. That was about 5 years back. But these are things that we tend to neglect taking a proper history. Whenever the patient has a miscarriages or a bad obstetric history, we always think about it. But these things, and now we find that SLE is becoming extremely common, and that is something that we all have to think about. A third scenario, a couple underwent IVF. The baby was found to have beta thalassemia. On testing the couple, both were found to be carriers. A golden opportunity lost, and I would say it is criminal. So this is something again, because now with the Human Genome Project, almost all the diseases, genes have been identified. And so it's very, very important. We have to have an idea. And Google is at your fingertips. So at least if you have a doubt, refer to a geneticist. Because I was just looking at deafness, congenital deafness. You find that there are four autosomal recessive conditions where congenital deafness, even hypo, there are congenitally AR conditions. So everywhere. So this is again something that we all have to think about. Now, adverse events in ART can be one due to the actual genetic the procedure itself, just like any surgical procedure, hemorrhage, damage to the adjacent organs, infection, which we are all thinking about. So try to avoid, look for a hydrosalpinx, etc. The adverse events which are unique to ART, OHSS, as the previous speaker has said, OHSS has come down in a big way, yes, and we are very grateful for that. Multiple pregnancies has to come down. Even the new ART Act has said, I think, 2 and 3 only in exceptional circumstances. We are a long way from single embryo transfer, but still, I think this is a stepping stone. And disorders of placentation, especially in frozen embryo transfer, think of preeclampsia, the large babies. So I think we need to move to natural cycle and stimulated cycles in these conditions. The third one is AI due to personal characteristics of the woman, and that is all the scenario that I showed you. Vascular adverse events, obstetric complications due to uterine problems, consider single embryo transfer or surrogacy, chromosomal and genetic risk for the child, the genetic conditions, and for the woman, Turner's and conditions like that. So ovarian stimulation, I'm not going into details, will one dose fit all? So that's what you need to think. In individualized ovarian stimulation, it's important to find a balance between cost, outcome, and safety. All three should go hand in hand. So this is just for your introspection. How many eggs do you actually need for a live birth? So is overstimulation, has it become the order of the day? Should we think about that also? Protocol, gonadotropins, dose, etc. Hyperresponders, as already said, the antagonist protocol, agonist, trigger, and segmenting of the cycle have definitely added to safety. There's no question about that. But there is a caveat to this, which I'll come to later. Poseidon, yes, but this was an interesting questionnaire which looked at, it was in 196 centers, and these are the different types of protocols. Majority, of course, were this. The greater the number of protocols there are, we always know, the poorer the evidence for any particular one. So in poor responders, the first prerequisite is to identify the poor responders, expected and unexpected. And in unexpected, consider inadequate dose or genetic polymorphisms. And in the expected poor responders, in group 3 and 4, probably something to prime. Agonist does work very well in 3 and 4, or a primed antagonist protocol. And in 1 and 2, probably the antagonist is a safe bet. And soft stimulation, especially when you're considering oocyte banking and very, very poor responders, probably it is definitely cost effective. Now, ovum pickup problems, and your response always depends on the patient factor as well as the efficacy of stimulation. It is important to ensure the type of trigger, timing, and the efficacy of the trigger, especially when you're going for an agonist trigger. The efficacy becomes important. Technical errors, suction pump, suction pressure, etc. Efficient and quick handling to maintain temperature, etc. Embryo transfer is the final and the most important step. So the timing, the technique, the cleavage stage or blastocyst, fresh or frozen, and endometrial preparation in frozen, which I already mentioned about. Think about all these things when you're thinking of safety. Anticipate problems. There is no room for surprises in embryo transfer, so mock transfer is absolutely necessary. The place of soft catheters and after of those things, and using firm catheters or a stillay in case of difficulty. Place of adjuvants like atoxaben, there is still very little, the evidence is still a little this thing, but probably in patients with adenomyosis and patients where you know who are will have a problem, you might definitely use atoxaben. Now, this is something which I found very interesting, the Davy lamp effect. I think many of you know what it was Sir Humphrey Davy who invented, I think that invented the Davy lamp effect in medieval England when mining was very, very common. So in mines they used to use these fire with candles, large thick candles were used, and as they went down into the mines, you found that the oxygen in the atmosphere was much less, and also there was an increased amount of inflammable gases like methane, and as a result, the safety of the miners was at real risk. Lot of hazards occurred, and that is why Sir Humphrey Davy brought out this Davy lamp. There is a candle inside, again a thick candle, and it is surrounded by wire gauze. So the principle of the wire gauze is that it dissipates the heat. So when it dissipates the heat, the inflammable gases do not catch fire. And another thing, the color of the flame changes to green, and it goes out when there is the estrogen, the outside atmospheric estrogen is reduced. So it was actually founded to help to go into. So what happened is that it was to reduce the number of adverse events and safety of the workers. But then what happened is that instead of initially there was a decrease in adverse effects, but later on there was an increase in the adverse effects. Safety was compromised, and that was because the miners were pushed into uncharted territory, and as a result of that, all the things they went deeper and deeper down, and then there were more and more of adverse effects. So could the reduction of one known risk bring on new ones? This is something that we have to think about, and this is an example, classic example of a Davy lamp effect. Just again think about. So has the antagonist protocol with agonist trigger and cycle segmentation lead to higher dose COS and very high E2 levels, bleeding after OPU, and in the process supernumerary embryos in PCOS? I leave it to you to think about it. Again, new gadgets in the IVF lab, PGT, ERA, MC, all these things. Everything comes, and classic example is ERA, of something which was developed in one lab and brought out without proper evidence, and finally now, as they say, it was an end of an era. So just like this, a lot of things are there, but what evidence do we have? Eshray has brought out this, it's a very nice paper, good practice recommendations, and I was surprised to see that the not recommended, just look at the not recommended list, routine hysteroscopy, ERA, all the immunomodulators. We've been hearing of immunomodulators right from the time I think I was doing my post-graduation. So if something has not improved in 20 years, probably there's no place. PRP, it's not doubtful, adjuncts, scratch, all these things. And in the lab, IVM, IMC, DNA fragmentation, MAX and PIXI also have not stood the test of time. Assisted hatching, PGT-A, PGT-SR and M, there is definitely a place, but PGT-A, a limited place. NIPGT is almost out, and time lapse definitely good for culture conditions, but whether it improves clinical pregnancy rates is something else. So what are recommended in clinical? Hysteroscopy for RIF can be considered, and in the lab definitely recommended is artificial oocyte activation only in selected conditions. FERT failure or globosospermia, embryo glue, microfluidics can be considered. Probably the cheapest of the lot. So this is again a real life prescription. This is another something. Just look at this, the dose of estrogen. This is a real life prescription. It's not made up. Just estrabet doses. And just look at this. I don't think there's any other route of progesterone left. Probably only a rectal route would be left. So dihydrogesterone, injection, sustain, or IM, all these things. These are examples of things which are coming. So are we justified in all this? And now there is evidence coming in that high doses of progesterone may be harmful. On the day of embryo transfer may be harmful. And even they say when you give high doses of progesterone in pregnancy, intrahepatic cholestasis is on the rise. Probably because most of this progesterone is converted to estrogen. So okay, coming to the lab factors, this is the reason, I think this year the Cairo consensus has been on the basis of future-proofing the ART labs, and we are very happy that India also has followed the steps, and the ART and surrogacy acts have come in. And it has been included. If you look at it, in the last one is India, the ART acts have also been included in the Cairo consensus. All ART centers should be accredited. Any compliance or violation from the provisions will be considered seriously. Third-party reproduction, in particular, to comply with the provisions of the ART Act. Coming to lab safety, this was even though it is in 2015, it was a very good paper, and I think still stands good today. The lab safety. Just a few words about lab safety in the lab. Lab personnel, qualified, experienced embryologist, Not only who know how to work in a lab, but most importantly, how to run a lab efficiently and safely. So take decisions, make changes as and when required. And the number of embryologists will depend on the number of cycles in a year. Design, materials used in construction, painting, flooring, furniture should comply with clean loop standards, minimize VOC release and embryo toxicity, ensure optimal workflow over minimum distances, minimize traffic in the lab, hand washing outside the lab. Air quality, temperature and humidity, very, very important, and the hallmark of an IVF lab. An independent HVAC system, preferably an AHU with changes, 15 changes per hour is probably the best, and filters to be changed routinely, or at least positive pressure ventilation. And the consensus on air quality is all tissues should be processed in a GMP grade A environment, and the background should be at least grade D, very, very important. The equipment, the type of incubators would, of course, a personal preference would be there. Yes, you have the box type and the bench type, and again, in the humidified and non-humidified, it would depend on personal preference a lot. But the number of incubators is critical and will depend on your number of cycles and the duration of your embryo culture. Validation, equipment validation, calibration, maintenance and repair to be done periodically and documented. Critical items like incubators to be continuously monitored, and backup for all critical equipment is absolutely essential. All consumables in media to be of embryo culture grade quality, appropriate refrigeration, the correct temperature during shipment to clinic to be verified, and off-gassing is always something that we do. Gases always outside the lab, automatic changeover system and sufficient cylinders for immediate replacement, high purity gases and inline filters are recommended. Cryo facilities again to be located outside but close to the lab, and this is part of safety. Adequate ventilation and safety alarms. You have safety alarms depending on the level of the CO2 and depending on the oxygen tension, oxygen concentration outside. So this is fair enough. In large labs where you have multiple, especially probably we don't have it in India, but abroad, especially in the US, they have these rooms are jam-packed with the huge cryo tanks. All staff to be trained in liquid nitrogen use and safety, and periodic inventory of cryocan contents is very important. Infectious agents hazard. Have separate cryocans for biohazards. Identification and labeling is absolutely essential, and ensure that your staff are vaccinated. So something that we many times overlook. So this is a sentence which I quite like, the previous Cairo consensus. There is only one thing that is truly important in an IVF lab, and that is everything. There's absolutely no doubt about this. So I'm not going, embryo culture requirements is probably outside the scope of my topic, mainly for the embryologists, but still we need to know all these things. Now remember, when we are working in IVF, we are working in circles, like the patient, the reception, the IVF results, and then it's a circle. There are also layers, the IVF personnel, the equipment, and quality control. And when you are working in layers, errors can occur. So to err is human, to cover up is unforgivable, and to fail to learn from your mistakes is inexcusable. That is a famous quote by Donaldson. Now, errors in the lab can be pre-analytical, analytical, or post-analytical. Pre-analytical is before the actual procedure. It relates to identifying your patient, labeling, rapport between the clinical and the lab personnel. Analytical deals with your actual procedures. And post-analytical is documentation, witnessing, and reporting the results. Now, unsurprisingly, error is most associated with pre-analytical and post-analytical processes and not the actual process. Errors can occur at any of these phases, and they can be active and latent errors. Now, active errors are those errors which can cause immediate harm to a patient or the system. It could be skill-based due to poor skills. For example, tripping. The junior person there trips and, you've had it, the dish has fallen down. So skill-based, knowledge-based, because you do not either have the knowledge or you're not able to apply the existing knowledge, and rule-based, when you're not the person is not qualified, there is a protocol violation and all these things. These are all active errors and absolutely very, very important and should be prevented, and you should learn from them. Now, latent errors are due to inefficiency in the system. They're easy to identify and prevent if you have a proper QC/QA in place. If you look at this, which is the one? This one? Oh, sorry. Which is it? This one? Top one. Okay. Yeah. So these are the these are actually the defense layers. These are all the defense layers in your lab or the system: the policy, planning, the design of the lab, and effective communication. And these are your gaps or weaknesses. For example, you're not conforming to the guidelines when you're setting up your lab or unit. Defective planning: if you have a low budget, your planning may be defective. Installation of substandard devices and power supply, and poor interdepartmental communication. So what happens is that these are all weaknesses, but you find in alone, or in what's the word? Yeah, in isolation, they may not produce problems, but when the wholes align, you find they can have a real adverse effect on the patient. It's also called the Swiss cheese effect. So when errors occur, what do? You have to have a root cause analysis, very, very important. So when it's an error, it need not be a big error, even a small error. It's not, like this, latent errors also. So create a time map, chronologically track the sequence of the event and the personnel present to find out the contributory factors. Very, very important. And then you analyze the contributory factors. Thirdly, make a cause and effect flow chart, all these things: materials, equipment, environment, protocol, all these things, and make recommendations for taking for tackling the root cause. And very, very important, document the action that you have taken, because that will help you or the people who come later. So risk management, this is a very famous everything. It includes everything: artificial intelligence, benchmarking, stress, quality control, electronic witnessing. What do patients fear the most in IVF? We all know this, isn't it? Mismatch. So never simultaneously control each step is one of the dictums of the embryologist. And so what do you do to prevent mix-ups? Identification of patients and traceability of the reproductive cells. So checking consents and each patient's unique ID code at each step. The traceability system has to be clearly defined always. Right patient, right procedure, yes, but also the right tissue. Each lab must have an effective system to identify, trace, and locate reproductive cells at each step. And double checking by a witness and or electronic witnessing strongly recommended at all critical points to ensure that mismatch does not occur. So witnessing, manual double witnessing is what we are all doing. Matching barcodes have also been used, and today you have RFID, which can be integrated into the workstation. But remember, whenever you use electronic witnessing, it must always be in combination with manual labeling of the bottom and the top of dishes and tubes to guarantee correct assignment in case of network failure or RFID failure, because always remember, gadgets can fail. And all labs should have an emergency plan in case of exceptional failure of infrastructure and facilities, and includes safety of all the patients and the personnel, protection of all fresh and cryopreserved material, and limiting damage to the equipment and records. The communication measures should be clear to everybody, and there should be regular revision of an emergency plan. Now, typical examples of facilities: electricity, uninterrupted UPS, yes, and generators to tide over 2 to 3 days should be available in case of a major power failure. LN2, reserve tanks should always be available. Equipment, power failure, always prioritize your critical equipment. You will have to prioritize when there is a long power failure, as can happen with natural calamities. A second spare should be available, validated, and ready for use. Backup refrigerators essential. And records to be on a secure web server always. And very, very important, third-party arrangements with another IVF lab. Probably not in the case of natural calamity, but in anything else. Coming to quality management, the key, how much time do I have? I have 5 minutes more?
Yes,
okay.
yes.
Thank you. So quality, and when you're talking about, I think quality management is the cornerstone of any IVF program. It includes QA and QC. And QA includes QC also. So what is QC and QA? Quality control is the process by which you want your program to remain stable. So QC enables your program to remain stable. You're looking at all the aspects which are directly or indirectly involved in IVF. Routinely monitor all these aspects and confirm them to be functional within previously determined acceptable limits. So your limits should be there, and you make sure that your everything in the lab is falling in those limits, and that means your program is stable. Without this stability, When you have an unusual outcome, it is very, very difficult to find out whether it is due to the patient-specific issue or to program failure. So if you're sure your program is fine, working beautifully, then you know it's probably due to patient-specific. QA or quality assessment includes QC as a subset by which the program, taking the lessons from learnt, the program undergoes improvements and corrective actions to maintain or improve. So QC will include QC of the lab personnel, ensure qualification and competence, very important. And that's why when we talk of KPIs of the individual persons also becomes important. Validated up-to-date written instructions of all procedures, SOPs. There is nothing else can replace SOPs. Equipment, maintenance, service and calibration. All the equipment should be done and documented. And the external environment of the gametes and embryos and air filtration systems should all be checked in QC. Materials and supplies to be tested, ensure identification and traceability and record keeping, and regular QC of your computers also. So this is a HFEA every year brings out the adverse events in fertility lessons, just like it brings out the confidential inquiry. And this is a it doesn't mention that this thing, within 48 hours in UK, you're supposed to report to the HFEA, and they bring it out every year. So very important, define the known hazards and risks. You should know what are the possible things that can happen, because unless you know what can happen, you may not recognize it. Maintain adverse event registers, very important, and even maintain incident registers. Any small incident, even something to do with the CO2 cylinders or something like that. So the next time it happens, you know what to do. Identifying and reporting errors non-punitively, very, very important. Please do it. It should not be punishment based. Only that is going to encourage a culture of honesty and learn from your mistakes. So grade A errors, according to the HFE, most serious but thankfully infrequent, for example, death of a patient or mismatch. Grade B, serious adverse effects including OHS's loss of embryos, breach of confidentiality, one person's details are given to another patient, equipment malfunction, or anything affecting embryo quality. And grade C is when many eggs become unusable during processing. So now that was all about QC. QA is both internal and QA is possible, because you're trying to make improvements, looking at everything by identifying all the errors and problems. Internal QA should be done regularly using your indicators, and the indicators should be objective and relevant. KPIs should be relevant, regularly checked and discussed. Just checking is not enough. In addition, operator performance, as I said, for each embryologist. External QA is also recommended. So do I really need quality control? Without doubt, the answer is yes. And we all know the KPIs. But one important thing is every lab should have their own gold standard. And in a gold standard, you should have the ideal patient. So for example, a patient below 40 or below 38, probably in our setting, non-use of TISA or any sperm surgical retrieval. So those good patients, find out what your KPIs are for those, and then everything you compare with that. So we all know the 3 levels of indicators, the RIs, the PIs and the KPIs. You have a minimum competency limit, but that is not enough. You aspire to be the benchmark level. So the reference indicators are actually a mark of ovarian stimulation. So that will just tell you if your stimulation program is good, the oocyte recovery and the oocyte maturity. And then you have the performance indicators, which is a measure of normal values. The most important is the blast development rate and your 1 PN. Polyspermy rate is not probably important in an IVF cycle only. PN rate also. And of course, you have a gamut of the KPIs, the crucial steps, the ICSI damage rate, the ICSI normal fertilization rate, the cleavage rate, and the measure of the whole team, the implantation rate at the cleavage stage and blastocyst stage. All these are important. It's almost over. A quality management system will not guarantee an error-free IVF clinic and lab. So in ART, the team makes the success. So talk to each other, the embryologist, the andrologist, and the gynecologist. So that is also very important. I conclude with these words of Hippocrates: as to diseases, make a habit of 2 things, to help or at least to do no harm. Thank you very much.
Thank you so much, Dr. Sheila Balakrishnan, for that insightful and thought-provoking session.